Let's take a look at ischemic stroke syndromes. Pure motor hemiplegia. Contralateral pons or internal capsule lacunar. So in vascular pathology, you can have these larger arteries that are affected. Let it be the middle cerebral artery, anterior cerebral artery, so on and so forth. Or there's something called a lacunar infarct. Say that your patient has had long-term hypertension. Remember we said that hypertension is an extremely common risk for stroke taking place. And if the hypertension is taking place over a long period of time, you can only imagine that there is really no blood vessel that is left safe. Right? So they're all vulnerable to some type of pathology. And say that you have little blood vessels that are now undergoing compromise and undergoing damage and injury. And at some point in time, maybe there is an aneurysm that takes place, and this aneurysm could be something like a Charcot-Bouchard aneurysm. And that particular aneurysm would be one in which little blood vessels, deep penetrating blood vessels of the brain that are being affected. So imagine that these little blood vessels are especially around the internal capsule, which is responsible for motor functioning on the contralateral side, right? So think about that from neuroanatomy, please. And at some point in time, after the aneurysm gets bigger, we know that anytime there's an aneurysm taking place, you're always worried about rupture, aren't you? And so therefore, when there's a rupture that takes place, you can only imagine now the little blood vessels, well, they're infarcted. You call this a lacunar infarct. And many times patients with hypertension will have lacunar infarct, but if that part of the brain is not significant in terms of proper functioning, and then the patient may be asymptomatic. But if it is an internal capsule that's been affected, such as a caudate or putamen or even the thalamus or subthalamus, and then you will have motor type of issues. And this would be a pure motor contralateral type of hemiplegia, wouldn't it? And so maybe, therefore, those interesting gaits that you've talked about earlier, where the arm might be adducted and the hand might be flexed, and then you have circumduction that's taking place of the leg, and you have internal rotation of the ankle and so forth, and you have that particular gait, right? And so that's referring to what's known as your pure motor type of hemiplegia, internal capsule. Let's take a look at another one. Pure sensory stroke, contralateral thalamus. Like here, once again, the little blood vessels that may undergo strokes, a lacunar type of infarct. Now, maybe it's a big blood vessel that has been affected, our middle cerebral artery. So think about that, please. So this is an artery that's been affected, and you know about your watershed areas, right? And by watershed, I'm referring to two blood vessels that are coming together, and when they do, it's that particular tissue that is now susceptible to damage. And so, for example, middle cerebral artery, anterior cerebral artery would be an area in which you call that watershed. And I told you earlier, middle cerebral artery would be supplying the lateral aspect of the parietal lobe, responsible for sensations and activity in the upper extremity, maybe the head and neck. Well, let's say that there is an MCA type of issue, and there is an atherosclerotic type of ischemic stroke taking place, then please understand that the hemiparesis will be taking place in the face and the arm, much more so than the leg, right? Because of the homunculus and the representation. There might be aphasia if it's the dominant side, sensory loss, it might be hemanopsia or eye deviation if there's enough damage of your MCA taking place. So keep that in mind. Aphasia, more or less, you're referring to the dominant side. How do you know what side of the brain is dominant in your patient? You're going to be looking for clues as to what arm your patient is more comfortable using, right or left, and then obviously the contralateral hemisphere is going to be the dominant side. Anterior cerebral artery. What about this syndrome? Well, here, think about the anterior cerebral artery, please, and you are supplying the medial aspect of your brain. And so, therefore, this then represents your legs and lower extremity. The lower extremity weakness, sensory loss, maybe even perhaps incontinence or limb apraxia. What does that mean to you? You're not able to carry out those learned motor type of functioning. Anterior cerebral artery. Where are you? The medial aspect of the brain. What about the posterior cerebral artery? Well, the posterior cerebral artery, more or less, think of it as being part of your occipital lobe, posteriorly. You should be thinking about vision. And there might be homonymous hemanopsia, Might be sensory loss as well. Then you have, from the circle of Willis, think about the posterior inferior cerebellar artery. Okay, so we have pica. And here, how's your patient going to present? I'm going to present like this, doc. So there might be hoarseness that's taking place. Doc, I'm having a hard time eating. So there might be dysphagia that's taking place, right? So if there's a couple things that you want to take out of what's known as Wallenberg syndrome and your pica, then you must keep in mind the big symptoms, such as dysphagia, such as hoarseness. So you might have ataxia, Horner syndrome, ipsilateral loss of face of sensation, contralateral loss of body and sensation if it's pica. This is referred to as being your Wallenberg syndrome. Now, with pica, would you call this a medial medullary type of syndrome, or would you call this a lateral medullary type of syndrome? Keep that in mind. I'll answer that question in just a minute. Why don't you come back and spend some time with me?